Okay.
All right, now we're good.
Okay. So, for instance, Dr. Nathaniel is the medical director of CTT teams. We have two, and he's sort of both the adult team and what we call the CTT-T, which is a transitional team. And the age group that we serve in the transitional team is 17 to 27. Not that they have to age out at 27. They can go for another year or two if, the appropriate transition is not there for them to go to an adult group. So here's someone, not uncommon, I imagine, that you see them in Boston. So age 26, she's already been hospitalized 25 times. Not all of it in psychiatry, sometimes for overdoses to the ER, to the poison unit, and then out, that kind of thing. And cross-sectionally diagnosed often as, oh, this is schizoaffective, this is schizophrenia, this is psychotic disorder, oh, this is mostly borderline, a variety of diagnoses. And so the situation with her was trying to get the insurance company that pays for her psychiatric care to agree that even if she had an underlying access to personality diagnosis, borderline features mostly, would she benefit from a longer term care, given that we've had such a challenging history, right? And so they finally agreed, because I think just adding up the dollar amounts of those 50 hospitalizations in a short period of time, they must have realized she's way more than $1 million patient in terms of the utilization of services. And so if we go to the next page, and we don't have to go through this page by page, because I can just talk to you, and please interrupt me as you feel best. But she identifies some of these dilemmas we face in young people. Mind you, she's 26, and in spite of the ACT team, she was still being hospitalized a fair bit, going to ER. What did she get from it? A lot of medical attention and surgical attention, depending on what she did to herself. And, in spite of the CTT teams going and saying, maybe she doesn't need a whole lot more, she could sort of split, our psych team versus the medical and surgical teams to demand much more services, just with her emotional dysregulation and putting them sort of in an anxiety state. I'm talking to the staff, in a hospital or ER. And so Dr. Nathaniel, the insurance people, and LTSR, where I go to 1 day a week, we have 2 8-hour doc time in the 16-bed. And I look after half the patients, and Dr. Kleinbelt, who's a child psychiatrist, looks after the other half. She also just spends roughly 6 to 8 hours on a Monday, and I spend 6 to 8 hours on a Thursday at this place. So we decided, given this history, we don't want to just keep going to 75 hospitalizations and all kinds of things, and maybe even the worst happening in some overdose. So we thought maybe we should just concentrate in the beginning on a diagnosis. Like, what is the actual primary diagnosis? Is it truly an access one, or is much of it related to borderline and trauma that everyone's missing in these super short-term hospitalizations, and the conceptualizations of diagnosis are just being missed in someone who's just 26 years old? So we decided, and the insurance company said, okay, take 6 to 9 months, because they must have spent a ton of money. I was even trying to get a cost, and they were very reticent to give me that number. But we just had a sense it was in the millions by then. So now that we had so much time with her, we spent a fair bit of time just trying to agree on the primary diagnosis being borderline personality with micropsychotic episodes and micro dysregulated episodes being called bipolar, schizophrenia, schizoaffective. And we eventually decided this will be our main working diagnosis. It's going to be bipolar, borderline personality disorder. So when I use BPD, or when Dr. Nathaniel and colleagues here use BPD, mostly they're not referring to bipolar disorder, they're referring to borderline personality. So, in this particular journal, which doesn't have an impact factor, but they do like clinical issues, we decided to send it to current psychiatry. We had to come up almost with sort of a clinical grand rounds type of thinking. So once we accepted the diagnosis, in the second half, on the right-hand side at the bottom, what would be the most appropriate placement? In classic borderline and trauma type thinking, you don't want long hospitalization. That's the last thing you want. But it was felt, in spite of this very high level out of hospital ACT team, she wasn't getting anywhere and was just being loaded with more and more and more meds. And so were these the right meds even for the long haul? So once the insurance company said, okay, let's go for not just home with ACT or supportive housing, let's go for this long-term structured residence. LTSR is what we use as the acronym here, and what Dr. Keshwan, was the medical director of when he was here. So they decided to go for this. And so we had this opportunity for diagnosis. And in the next part of this article, we talk about, once we accept this as our working diagnosis, what are our observations? So we decided, maybe once we agree on the diagnosis, we should develop psychosocial treatment skills, because for what is there for the borderline patient by way of pharmacology? There's a little bit out of McLean, as you know, on the use of clozapine even, or other, antipsychotic drugs, pre-clozapine. There's a little bit that we've put into the literature on cases and case series on using clozapine, all the way to clozapine. But in her case, was this kind of pharmacology really necessary at the age of 26? Or should we have been planning, trying to get rid of most of these and just have her on maybe something a tad more benign, maybe SSRIs, maybe the occasional use of sleeping pills if needed. And most of it should have been some version of DBT-driven skills training that she was already, it's not that she wasn't getting some of these, but maybe that's what we needed to do. And to wean her away from this excessive med surge. I even showed her like an Excel sheet on the first treatment team of the number of hospitalizations in ER, overdose. To be honest, she was a little shocked at the number, because I think it has just become so part of her. Even the ACT psychiatrist, that's Dr. Nathaniel in this case, he's the first author of this, he himself was surprised, because once you take this and spend time doing it, and administrative assistant, she did a fantastic job of pulling everything, even hospitalizations that weren't in our system. The county was willing to give us these, de-identified claims data to show how much of utilization of services. And it was incredible, even to her eye or to the ACT team, doctor's eye. So based on this, the next question that came up is, okay, if we have to use pharmacotherapy and mainly psychosocial treatment driven goals for her, what is it that is pharmacologically evidence-based to use in borderline personality disorder? And, a lot of you are seasoned in this, and if we just looked at what should be the treatment if we go beyond this table even. So this simply describes the rationale for long-term treatment with someone like her phenomenology, utilization of services in long-term residential treatment, which is not ideal for borderline personality disorder patients with trauma, as you well know. But somehow here we took the opposite approach and decided maybe we do need 6 to 9 months with someone like her. And so we went down that, and so then if we went down further on this article, what could we get rid of pharmacologically and how? And so we decided, we were going to go after the antipsychotic meds. So she was on olanzapine, right? And if you go down further, Dr. Keshavan, so this is what we did. The difference, Dr. DeLisi, was she's living with us, 24/7 nursing. It's pretty expensive, the 16-bed project for the county, but they pay for it. There's about half a dozen, one of which is purely forensic even, and one predominantly only for men, in fact, only for men. And there's 4 others. Ours is co-ed. It's been running since Dr. Keshavan was here. So it's been running for a good 3-4 decades at this point. And it's changed a little bit in its format and who comes to us. But this is what she came to us on from the hospital. 20 milligrams of olanzapine, and 30 pounds later, an injection, like a long-acting injection, 150 milligrams once a month, benztropine to cover the EPS, melatonin. So we essentially went initially after olanzapine, and we kept decreasing it over a 3-month period, and nothing happened. She just began to lose weight, in terms of psychosis reemergence, mood dysregulation, kept going, but it was no worse than her baseline, to be honest. And splitting, no worse than her baseline. Then we went after Haldol D, and that we took longer. And then we went after the benztropine. We eventually went after this 9 milligrams a day of melatonin. Then we had to restart a lower dose. So I think the advantage of having a longer term inpatient stay, not paid at inpatient costs, way less, obviously, but it's not exactly free either. It's still a bit pricey because we have 24/7 nursing. We have less people on the night shift, and we have 2 doctors who spend about 6 hours per week each on these 16 patients. What was the eventual outcome? So, it's surprising that we discharged her on practically nothing other than for her blood pressure and a little bit of melatonin. In the first 9 months post-discharge, she was hospitalized twice, started on Geodon for these micropsychotic episodes, but Dr. Nathaniel was her doc in the community, and he quickly took her off it. In the nearly 2 years when this was written up, now she is several years, post-discharge, she's had 2 or 3 hospitalizations, 3 or 4 ER visits, but she's living in the community. And the main drugs that seem to help her, in addition to a heavy dose of DBT, is sertraline and melatonin. Occasional use of hydroxyzine for anxiety, but because of the anticholinergic burden, Dr. Nathaniel takes her off. So I guess what I'm trying to say, is all psychosis always psychosis, at least process psychosis, or is it something else in these young people? And in these short stay, very rapid hospitalizations, have we lost the value of the somewhat longer stay, like the old state hospital longer stay units, but out in the community? In this place, there's no forced med protocol. We can't put our hands on them. There's no, if we needed security, we have to call the sheriff or the police. It happens every now and then, but that's kind of where we are. It is seen not as an inpatient unit, but as an adult mental health residential facility with its own Commonwealth of Pennsylvania regulations. There are a few around the state, and the regulations are tad too old, in my opinion, needs badly to be updated. It's like almost, 1990s type specs and regulations, badly in need of updating. But that's to give you a sense. I think it addresses some issues, but not all issues of someone with clear-cut psychotic diagnoses. So I'll stop there, and some of you may have questions, comments, but that's just one example of our deprescription. We've done a few more of these, obviously, other than just her.
Oh, thank you, Roy. I think that was a fascinating case. There are very few such descriptions in the literature of a thoughtful, gradual pharmacologization of individuals with complex disorders. What I am taking from this are a couple of key points. One is psychotherapy is probably very important and is often not given the same primacy as it should be. And, especially with recurrent hospitalizations for someone like this, our tendency would be to be in a hurry to stabilize things quickly and keep loading medications. And then when they come out of the hospital, our tendency is not to mess with what was done in the inpatient. And so they keep, it's like an accumulating bin of polypharmacy. So that it requires to be addressed through, a focus not just on medications, but on a combination of psychotherapy and medications. The second key point that I take from what you're saying is that diagnosis is so important. We just make a diagnosis of schizoaffective disorder and assume that is what it is. And for years and years, the diagnostic label doesn't get peeled off. And we don't rethink, about whether it might be something else. And so, this is a great example of a careful diagnostic approach could clarify our own rationale as to why we are doing what we are doing. The third point, which is more of a question for you, is obviously, a residential program like the LTSR would be expensive.
Yes.
Could something similar have been done in a day hospital program like TLC, which you have, right?
Yes.
Yeah.
We sort of retired it for a while, Keshwan, because the regs here for day hospitals changed so drastically that people said in the mood disorders clinics, they're doing it like the way the regs are supposed to be. Somehow in the one that we had here in schizophrenia was retired, and we've reawakened it with this new format of funding, sponsoring, which we call IOP, intensive outpatient, partial programs. So unlike the old TLC day hospital model, so they have to come a minimum of 3 times a week, 4 would be ideal, and spend at least 3 hours in groups or individual therapy. And they typically funded for 8 to 12 weeks. In the past, if you recollect, some of them would stay for months and years, even in psychosocial
that's
rehab.
what I remember,
Yeah, psychosocial rehab programs. So a lot of them, because of the lack of funding, have been removed. And we're trying to reawaken some of that, because I think, as you know, working with this population, sometimes we are the family.
Yeah.
And it's hard to sort of put into words for people who just pay for services. But, as you know, well, it's kind of what keeps them out of hospital and out of trouble and crises. So I personally feel the IOP, we just got it restarted, Dr. Gannon, Jessica Gannon, and new administrators here, Kelly, O'Toole, who's runs the mood disorders IOPs. She runs a very successful 11 tracks of IOP from borderline to bipolar, but nothing for schizophrenia. She has helped set up the schizophrenia IOP because she's so well versed with what the payers want, what the prescribers want, what the therapists want. So we've just got it restarted in April. And one of my goals is literally, you brought up this question right on point, which is literally to do that.
Yeah.
Because that is an expensive business, the other one.
Yeah.
And that they have so many criteria, like we had to literally bleed on them for her to be with us for 6 to 9 months. Because they're trying their darndest not to send anyone there, even trying to close it down. But just given the population base of Allegheny.
Well, what might be of value, Roy, is if you were to compute the cost of her 25 hospitalizations prior to this experiment, and then compute the cost of her care after this experiment, and publish that.
Yeah, I wanted to do it so badly. They were so reticent, the county, to give me the claims data. But I told Vernon Nathaniel, the first author, if we could just show what has happened in the 4-5 years since discharge, because she works at Wendy's, she lives in her own apartment. She has, the access to is not going to disappear right away, but she's older and some of it is burnt out. Some trauma therapy, I think, has helped stabilize her too, in addition to the borderline sort of therapies going on. And I suspect if we looked at just a bar chart, you wouldn't even need stats. That's my hunch.
No, my point is, if you know what the hospitalization inpatient bed rates are, right? And you can easily get what it was, say, a few years ago. And I remember Western Psych was charging $1,800 a day when I was there. And it may have come down a little bit, but still, even if you say she was hospitalized for 20 times, each time about 2 or 3 weeks, let's say, 20 times 20 would be 400 days, let's say. And if you said at an average of $2,000 a night, it's it's staggering.
Yeah,
you can compute that.
And then the ER visits. Can you imagine the ER costs? For 8 hours, 12 hours, and just boarded for 23. And
and it is the county that will be saving the money, because it is the county that bears the brunt of these kind of costs. Right?
So we do have that Excel sheet. I'm going to have Vernon dig it up. And we can look at the claim, because I even got him from the older county, data people. Right now we have a tough group there, but they were very cooperative with us. They gave him a username and password to look at all claims from the county, not just Western Psych claims. So let's see if we can even resurrect that. He does have that for when we started her, and we could certainly get the claims in the few years after.
Right.
Yeah,
and also we had to add to that the cost of her, whatever, olanzapine.
Yes.
It adds up.
Yeah, and even though, Haldol D may not cost as much, but as an injection, it does still cost some money.
Yeah, it does cost.
Yeah. Right. And maybe benztropine is just cents on the dollar. But all of that is pill reduction, burden reduction, fewer pills. The other thing that we did, I forgot to mention this. This may be an important one. We collaborated with the 2 ERs she loved going to, and had the nurse manager and the main ER doc work with us on figuring out what is truly med-surg and what is not. So sometimes she would not be taken in quickly, as you know, in ERs, you could be waiting. So at 3 in the morning, she would have gone in with something that they decided wasn't anything that they could do medically. They would send her back to us at 3 in the morning with having given her Tylenol and maybe a little bit of dinner at night.
Mm-hmm.
So that itself began to extinguish some of the reinforcement behaviors of how
Sure.
much medical and surgical attention she was getting.
Yeah. We have lots of these kind of patients.
Yeah.
Like,
And if you have a champion type ER doc, ER nurse, ER social worker, you're in luck.
yeah, it's true. I'm sure others have thoughts or questions.
I was going to say, Lynn's got her hand up.
Lynn?
Yeah, so Kesh, I agree with all your points. And also want to emphasize, like you were just doing, that this is a patient that because you were able to keep her long term, you were able to reduce her medicine and really reevaluate her medicine. So I'm looking at what can we do in Massachusetts? This is a very unusual situation. So we have lots of hospitals, but the patients come to the emergency room. There are electronic bed searches. They get put in a hospital. They may never have been seen there. They don't go, there's not continuity of care. They go to a hospital. They want out.
Yeah.
Okay, they're sectioned, committed for 72 hours, but after that, they have to be released unless they sign in. Even if they sign in, they can sign out, and the doctor only has 3 days. They don't want to stay confined in the hospital.
Yeah.
But say it is a patient who's been in and out for 20, 25 times, and you want to really reevaluate the medicine. The patient agrees. Maybe the judge has committed the patient.
Yes.
Okay, then you try to get them in a state hospital where they can stay long term. And there's a huge 1 year waiting list.
Waiting list.
Waiting list. Terrible. You can't get them in.
Yeah.
You can't, if their family has lots of money. The only place I know of, and there are a couple of others throughout the state, but is McLean, where you can put them in a residential program for cash.
Or the Gold Farm. You can send them to Gold Farm.
Oh, yeah, you could send them there too. But a residential program in general costs lots of money.
Yes.
And cash, McLean doesn't even take insurance in some of these programs. So that's a problem. Can you take a patient like this, and on an outpatient basis,
Yes.
take them off of the medication? And I wonder, it's crazy to have them on, this is polypharmacy too,
Yes.
antipsychotics,
Yes.
high doses, even high dose of melatonin, which is, not a good idea.
Yeah.
And I
Do you
would
think,
probably,
Dr. DeLisi, do you think like the Office of Mental Health, I forget what it's called in Worcester, but the big mass.
The DMH.
Yeah. Like if say they were to take outliers between the ages of say 16 to 35, I'm just making up this number age-wise, and say they have in a 5-year period 25 hospitalizations or 20, or they can just look at the data and you can be informed by the data, and you can take the outlier population and say, do you think instead of spending, to Dr. Keshwan's point, millions and millions on these ER visits, no one knows anyone, there's no continuity of care, and say it's worth an experiment to try maybe 90 days of an intensive outpatient program where they don't even have to come in, but if there is some place where they can be supervised and court ordered to be, at least to, that has some like carrot and stick to them. Sometimes they go along with the legal constraint more than they do with our shared decision making, and say they're able to come in 4 times a week. You have eyes on them, many eyes on them, not just one set of eyes, many sets of eyes, and then you can say we program this for funding for an experiment or a pilot for 1 to 2 years minimum, would it be worth your while? Because in fact, yeah, not just these mandated things from Massachusetts, which have said, let's take off the second antipsychotic, let's take off the third antipsychotic. Here we do it thoughtfully, even to reconsider the diagnosis.
Yeah, well, of course, this is the wrong time to be, asking for funding to do a new program. But I think, I mean, Cash, we should really think about being creative about this and working with DMH to see if there's any flexibility in the system, because it's not working the way it is for many.
Well, this is definitely worth developing as a block grant proposal
Yeah,
Yes.
yeah.
with a cost saving goal.
Yes, because ours is block grant, by the way. LTSR
really?
is
Yeah.
based on a block grant. We haven't gone for fetus. We've been resisting, but you can see the pressures on the county and everything. But they have decided, since there is almost no, the state hospital here closed, so our closest state hospital is 2.5 hours away. And they only take our forensic patients from our county.
Mhm.
Yeah.
They don't even take our civil patients.
But maybe if we focused in a grant on patients who are on polypharmacy because of this
Yeah,
situation.
yeah. Yeah, you can have the criteria, if they have
Yeah.
had more
Yeah,
than 10
yeah.
hospitalizations in the last 5 years.
Exactly.
Something like that, yeah.
Exactly.
And they
Yeah.
will know the claims data and what they've paid out, even in the
Yeah,
block
yeah.
grant.
Oh,
or,
yeah.
or even in the fee for service grant. They know exactly how much. And say you just took that, maybe not the 5th percentile, but the 10th percentile, the top 10 of this outliers, and say, maybe we don't even know the diagnosis in this group. They're all cross-sectionally evaluated. They're out on the street in 72 hours, maybe 5 days, and they know better. And look at these hospitals, and they're all young people.
Mm-hmm.
And why not sort of give them a break and try something? Massachusetts usually is good at leading these kind of things. So I don't know if you have a DMH ahead who's open to that. And
Oh, we do.
Yeah.
Sure.
Yeah, we do have a good progressive department.
Yeah.
yeah,
They are financially strapped, but yeah.
but here
Yeah.
you
I
might
think
show that how much have these guys utilized this 10 percentile. Maybe they've utilized a third of your budget. Accidentally, these guys made the mistake in the county. I'm just telling you this confidentially,
Yeah.
of showing me how much 302, what you call section, Dr. DeLisi.
Section 12.
Yeah.
Yeah.
Right.
The 302, how much they cost them.
Yeah.
Because
Yeah.
just
Yeah.
because they got released and overturned, it didn't mean they still were
Yeah.
Yeah,
Yeah.
still the
claims in
judge's
every
time,
which
yeah.
way, from the medical side, from
Oh,
the
yeah.
psychiatric side, the ER, the crisis center. Oh my God. And they showed us that they accounted for 20% of the
Yeah.
annual budget. They
And-
weren't supposed to show it to me, but of course they're playing around with all these Excel sheets, and I quickly, it caught my eye and I tucked it away in my head,
Yeah.
so.
So these are patients also, if we focused even on the early first episode cases that aren't doing well, that are, going in the emergency room all the time, these may be the patients who you really need to start earlier on clozapine.
Yeah.
And
Could
what's
be.
a better place to take them off of their medication than a program that we're talking about? And to start them on clozapine, and
Yeah.
regulate it.
Like
there's a lot-
clozapine, lithium, lamotrigine, these are titration,
Yeah,
and you can't sort of do it in 5 days, as we know. To some extent, the same for long acting. And so I think I have that youngest I was telling you, he just turned 23 last week. So he's on clozapine. Dr. Khan, who, Dr. Keshavan mentored out here.
Chuck Khan. Yeah.
Chuck Khan, yeah. So he, in the long-term unit, the true unit out, he's at McKeesport mostly, Keshavan now. And so he put him on clozapine. At 23, he's had 5 hospitalizations.
Mm.
And, and what I'm beginning to peel off, Chuck had to send him because you could only keep him there for X number of days, is he's on 350 of clozapine, and he's from, this middle class ethnic minority family, was big, and he was headed for Division I football. So I don't even know any concussions and practice things he's had, and he's still quite psychotic, but I'm beginning to peel off the second antipsychotic. He's on 3 antipsychotics and lithium.
Yep.
He's,
Yeah.
luckily for him, he's 6'6". Even with the weight gain, his BMI is 24. And, but that's just because of his height and his body structure. He's like a Division I kind of body structure, college football. And so he towers over all of us in the place. He's very polite, very, nice upbringing. And, as luck would have it, he has the first seizure when I was away for 1 week. And of course, everyone wants to take him off clozapine. And I had to call from out of town, talk to the ER doc. I just split his dose. It was all being given 350 at night. I split his dose, 150 in the afternoon and 200 at night. And, it's been a month and a half, no seizures.
Did you
Fingers
put him on
crossed.
an anticonvulsant?
They did, and they decided, because it was a single seizure, they didn't want to continue the Depakote. The last thing I wanted was for him to have some more back in our hospital from the ER, and so I kept him going on Depakote for 4 weeks. I've tapered him off just about 3 weeks ago. So far, so good. But clozapine, age 23, and his mom tells me 80% better compared to the last 5 years. 80%. She's very articulate, participates in every treatment team, shows up to take him out on privileges. Dad shows up. Dad's busy into commercial real estate. But this is what clozapine has done to a 23-year-old. He has established schizophrenia. He was here in the STEP program with Deepak Sarpa and still led to 5 hospitalizations.
Yep.
You mentioned he was on 3 antipsychotics.
So he was on, they put him on Abilify and Invega.
Yeah. Is there any scientific evidence that 3 is better than 1?
Not really, not in the short time frames they have to evaluate it. And he doesn't spontaneously bring up anything with me, Dr. DeLisi, or with his primary therapist at the residential site. So what he does is, he goes home on these passes on the weekend. He goes to church and then they take him home and then they bring him back. And sitting in their garden, the mom told me at the last treatment team, which was about 2 weeks ago, that he said, "Hey, Mom," because, he considers them clones. He still doesn't fully believe that they're his real parents. So he never brings it up with us. We don't poke the bear too much with it, and he doesn't self-talk. All that has gone. But he told her, "We're still in like a screenplay, right?" So she said, "Hey, so-and-so, what do you mean by that?" You know what I mean. He's got enough what I call medication insight not to bring up the obvious. So he won't bring up like something crazy because then she'll obviously tell us. So he now talks in innuendo around the topic. So I told her, "Isn't that itself a little insight?" She said, "I thought so, but I worry, is he hiding too much, or is this just he's got enough medication insight to sort of bring it up to this point but not push it?"
Over the years, I have realized that, even if a patient begins to kind of push their delusion aside and not bring it up in conversation, that itself is a remarkable sign of improvement.
Exactly. And so I brought it up with her and she said, "I couldn't agree with you more. Before it was so spontaneous, I didn't have to do anything." And so I said, "What was your counterpoint to him?" She said, "I don't know if I did the right thing." I told him, "Hey, so-and-so, how about we do it like a script? And maybe you could use some of your, he likes drawing and this and that. So she said, maybe you could be the screenwriter. What do you think? He said,
Mhm.
okay,
Hmm.
maybe I'll start with sketches. So that's where we're at now with
It's
clozapine.
wonderful.
And
Yeah.
clozapine is just about 5.5 months of clozapine.
Mm.
Yeah, I guess clozapine doesn't give insight, but it puts a distance between the symptoms and the person, I
And
guess.
and other things can happen.
Yeah,
You know,
and so that,
I-
he can get on with his life.
Yeah.
So,
I want to get him into Sean's spaces, what
Yeah.
you're doing in your PCORI, the CET versus
CET,
SST.
yeah,
So I want to
yeah.
get him to work with Sean's group for
Hmm.
CET because we see leftover negative symptoms.
Yeah, it's fascinating.
Yeah.
No, these are all very, very, very insightful points, Roy. The diagnosis is an important one, and the earlier the one makes a accurate diagnosis, the better for us and for the patient in the longer run. I'll say one small example of a case that I saw in Detroit, where I also developed another clinic similar to your STEP clinic, which was
Yeah.
also called STEP clinic.
That's interesting because
Yeah.
we were
So-
writing the history and we said Dr. Keshavan founded this just the other day. Yeah, I think it
Yeah.
crossed 30 years.
Yeah.
Yeah.
And so in this the STEP clinic, I was referred a case of a man in his 40s, and he was, just wondering whether he needs so much medication. And so he had a diagnosis of schizophrenia for about 25 years.
Ah.
So he was on, believe it or not, 300 milligrams of oral Haldol.
Oh my God, oral.
Oral 300 milligrams of Haldol.
And walking around as if
And
nothing.
walking around as if he is not taking anything. So we brought him in for an evaluation and we looked through his tons and tons of medical records. He has had a few hospitalizations. Each time he comes with, feeling a little anxious, and they increase the Haldol and it keeps on going up. And nowhere is there any clear-cut psychosis over the 20 plus years. And he worked in a state hospital. It was very easy for him to walk to the psychiatrist there and get his medications filled and so on. So the only thing that led to the diagnosis of psychosis, it turns out, was 25 years ago, he had an acute psychotic episode and he had been using marijuana heavily at that time. He stopped marijuana and the psychosis stopped. And, the psychosis never came back. Only some anxiety came back. But the cannabis did not come back. But people did not revise in their minds to think about whether this could have been simply a cannabis-induced psychosis.
Yeah.
So we had the advantage in Detroit of a researched inpatient unit.
Yeah.
So we said, we'll bring this person in for 2 weeks and get his medication cleaned up. So we brought him in, and over 2 weeks, we cut down his Haldol to 5 milligrams. No change at all. And then he was discharged, and he continues to do fine.
Amazing, isn't it? Yeah. We had Cyril Deepak D'Souza here for the
Yeah.
schizophrenia conference last year. You should invite him to these grand rounds and present a cannabis case.
Yeah.
One or two cases, because
Mm.
his presentation was like something very clinical, very sound, and he shows the intoxication, the amotivation, old negative syndrome with excessive chronic use of cannabis, the comorbidity with psychosis, the comorbidity with schizophrenia. And when do you say that was just a sidebar issue? He has processed schizophrenia. It's beautiful, the way he presented. And so I think he would be really someone great for your,
Yeah, no, I think
Yeah.
I'll keep that in mind. Deepak is really very good, and I didn't know that he has this clinical, side to him.
Yeah,
He is, of course, a top-notch researcher
of course.
in the area of clozapine and prediction of our antipsychotic response.
Yeah.
So we should bring him in for that as well.
Yeah.
to
Yeah,
speak on that.
absolutely.
Yeah. But this was wonderful, Roy. Thank you so much.
Thank
It's
you.
always
Thank
good
you
to
all for staying in. I hope.
bring clinicians.
Yeah, it was.
Yeah,
Thank you
please,
for inviting me.
you know, I think you should pursue this and write it up more.
I'm going to push Vernon, Nathaniel. We've talked about what you exactly said. I said, even if we don't get it into a journal, let's just show it to our insurance company. And my hunch is they already know, but let's show them something that
maybe,
we also
if
know.
you send it to Psych Services, Lisa Dixon would love a paper like this.
A single case, you think?
Single case, yeah, I think
yeah.
so. Yeah.
Okay.
Yeah. All right. Mostly I've been talking, and Lynn.
Yeah, Lynn just
others?
had to step out. Yeah.
Yeah. What about others? Any other? Sarah, do you have any thoughts, questions?
I don't know. This was very helpful. These are all issues I think about all the time. So it's nice to kind of hear you guys talking about your experiences and some of your thoughts.
Thank you.
Yeah.
Really appreciate it.
Thank you.
Thank you.
Always great to have you, Roy. We'll love bringing you back at some other point on a related topic.
Thank you. Everyone's excited, by the way. You're going to do the schizophrenia conference presentation.
So, we do have some interesting findings. We'll share the PCORI. I'm talking about the PCORI results.
Yeah.
Because of the pandemic, our ability to get a full complement of what we proposed was not possible.
Absolutely.
Smaller sample.
Yeah.
But still, we have some interesting findings.
Data. That's wonderful. Yeah.
All right. Thanks, everyone.
So have a good afternoon, everyone. Bye-bye.